This video will demonstrate the use of submaximal angioplasty for treatment of symptomatic basilar artery ICAD. This is the case of a 69-year-old man who initially presented to the emergency room with symptoms of dysarthria, facial droop, and arm weakness. On formal neurologic exam, he was found to be awake, alert, and oriented, but did have dysarthria, a right facial palsy, and right upper extremity weakness. He was on aspirin and clopidogrel in the form of best medical management for his intracranial atherosclerotic disease. Non-invasive imaging demonstrated a basilar stenosis on the order of 80% with left pontine infarcts. These vascular imaging studies demonstrate the region of stenosis in the mid-basilar, and the axial DWI demonstrates restricted diffusion in the region of the brainstem. We obtained left brachial access for access to his left vertebral artery. A wire is advanced into the mid-cervical portion of the vertebral artery, and a catheter is advanced over the wire and into stable position within the vertebral artery. Brachial access is often significantly easier for obtaining access to the vertebral arteries. Angiography demonstrates the mid-basilar lesion that was observed on prior non-invasive imaging. We return to a cranial cervical view of the vertebral artery so that we can navigate the complex turns around the C1, C2 region. Once this has been obtained, we then proceed with another diagnostic run in order to obtain roadmap guidance. Under roadmap guidance, we will advance our wire across the stenosis. When advancing a wire in the region of the basilar artery, it is helpful to keep the wire pointing anteriorly so as to avoid the posteriorly directed perforating arteries. Once the wire is across the stenosis, we proceed to place it into a PCA artery. With the wire in place, we can then advance a balloon catheter across the area of the stenotic lesion. The balloon is inflated over the course of several minutes. Ideally, we inflate 1 atmosphere every minute up to a nominal pressure, at which point we hold that nominal pressure for 2 minutes prior to deflating. We see on this follow-up run that there is increased flow and the basilar is open.